You on 8? You on 8. Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orpit, and today we're going to talk a little bit about some medications. And so medicine is an ever-evolving field. The amount of medication options for disease processes often feels staggering and overwhelming at this point. Diabetes is no exception. It used to be all that we had to worry about was metformin and insulin. And then we started getting different short and long-acting insulins, which, okay, was still manageable, but over the last decade, we've had a flood of oral agents come on the market, and each one of these classes lowers insulin through different mechanisms. It becomes confusing trying to remember which of these medications do what. Some can cause severe hypoglycemia and some don't. Which of these medications should catch our eye on a patient's medication list? So today we're going to go through these classes and try to differentiate which ones we need to worry about. And at the end, we'll talk about a really good tip to keep all of these straight on your next shift. Since we're talking about medications, we of course asked for our emergency pharmacist, Lance Ray, to come help us out. Lance is no stranger to the show, and we're super lucky to have him back on the show today to help us sort this out. Lance, welcome back.
Thanks, Ross. Thanks for having me. Good to be back. Always good to chat about medications and try to clear the muddy waters on what's going on out there. There are so many medications, like you mentioned, and it's really hard to keep them all straight.
Exactly. So I guess we should first start this topic out with just a primer on kind of how our body normally handles glucose in our bloodstream.
Glucose is in your bloodstream. After a meal, postprandial, your body recognizes that, right? And your pancreas releases insulin. That insulin's floating around in your body and attaches to insulin receptors on your cells. Think of maybe all the cells in your body for the most part, and helps uptake that glucose into the cells. Type 1 diabetes, when you have an absolute deficiency of insulin, your pancreas just does not release insulin. That's a big problem. So you have to have, from day one or from whenever that's diagnosed. It's usually in childhood. And you're on insulin for the most part, unless you get a pancreas transplant for lifelong. Thankfully, there's a lot of new treatment modalities and insulin pumps, and they're really getting advanced. Type 2 diabetes, which is sort of later onset diabetes, a lot of times associated with a lot of comorbidities, metabolic syndrome, is more of a insulin resistance, and it's gradual, and you might not need insulin at the beginning, but eventually all of your insulin receptors sort of stop working. And again, you can start with an oral drug. We can help the insulin receptors be receptive, for lack of a better term. But then a lot of folks often end up needing insulin. So that's kind of the rundown on the pathophys behind diabetes. Super interesting.
Okay, so when we talk about diabetic medications, how do you recommend we break these down?
Yeah, so again, like you mentioned, so many medications out there. So I think it's helpful to kind of put these in different buckets. I like to divide these medications into our hypoglycemic agents, ones that really lower blood sugar, and that's what they're supposed to do. Insulin is one of these, and there's some other agents that help insulin be released, and then non-hypoglycemic agents. So these are agents that might help sensitize those insulin receptors or do some things to glucagon and other mechanisms to the pancreas to where they sort of suppress one thing and maybe activate another, but they're not overtly sort of hypoglycemic agents. So we've got our hypoglycemic agents like insulin. We have our non-hypoglycemic agents, which are more adjuncts, but they still can be a little, so we'll dive into those.
So let's start with the hypoglycemic agents.
Yeah, so obviously a cornerstone of hypoglycemic agents is insulin. There's lots of different types of insulin out there. I know that can be intimidating. I recommend doing like a Google image search on insulin pharmacokinetics or types of insulin, and it can give you a good graph instead of me just listing off a bunch of numbers and hours on how these work. So our insulins range and are different mainly from their onset and their length of action. Otherwise, they're all essentially the same. And, if you take a short-acting insulin, a certain number of units, for 24 hours, you could add that all up and kind of get the same as a Lantus, a long-acting insulin. So in terms of the units, a unit is a unit. And I think a unit of insulin was originally described as the amount of insulin that's given to like a 1 kilogram rabbit to lower their glucose by a certain amount. So a unit of insulin is very standardized, but when you apply that over a long time frame or a short time frame, they can obviously be different.
Sounds like a very English measurement. It's like feet.
Rabbit.
What other medications do we have in the hypoglycemic?
Yeah, so then our other big kind of hypoglycemic class of agents is our sulfonylureas. And there's essentially 3 of these: glimepiride, glipizide, and glyburide. They all have brand names that are associated with them also. These are hypoglycemic. These directly stimulate the insulin release from our pancreatic beta cells. And so it's just like insulin. These are important to have carbohydrates at the same time. We counsel patients need to use these at mealtime. And if not mealtime, or in the unfortunate case of an overdose, they can cause profound hypoglycemia.
Yeah, these can be scary overdoses, and they can cause a lot of rebound hypoglycemia and kind of hang out for a while too. Yeah, oftentimes they may require going on a D10 drip, especially if they took too much of them or have an overdose, and be observed for prolonged periods of times. And they're especially scary in kids, where we talk about even just one of these pills in a kid might cause profound life-threatening hypoglycemia. Other than glucagon or dextrose for these patients who are hypoglycemic from sulfonylureas, are there any other medications we think of in this overdose?
Yeah, it's a great question. Octreotide is one of them that we would use in a sulfonylurea overdose, and it's got an interesting mechanism, and it actually works downstream of where the sulfonylureas are working on the beta cells of the pancreas, and essentially actually just suppresses that insulin release from the pancreas downstream of where the sulfonylureas are stimulating. But just as you alluded to, it certainly goes in the sort of one pill can kill category, or if not, at least one pill can certainly harm a child if they were to take this. And I'm glad you mentioned the rebound hypoglycemia. D50 will stimulate pancreatic insulin release if it's a type 2 diabetic, and you can still release insulin. So just by that virtue of giving D50, you can actually cause some insulin release too. Of course, it's necessary, but that's a lot of times why we will end up starting a D10 on someone to get a bit more of that sort of steady dextrose infusion.
Does that do it for our hypoglycemic agents? Are we on to our non-hypoglycemic?
Yeah, so that's essentially it. Or some of our non-hypoglycemia agents, disclaimer, some of these can cause a little hypoglycemia, but really the insulin and sulfonylureas are the big ones for the hypoglycemics.
So what's in our non-hypoglycemic category?
So our first line therapy for diabetes type 2 is metformin. Metformin's one of the top 5 most prescribed drugs in the U.S. So it does not cause hypoglycemia. Like I mentioned earlier, it really just sensitizes the insulin receptors on the cell to uptake insulin. And actually metformin, probably a reason that it's number 5 most prescribed drug in the U.S. right now is that it's got a lot of off-label uses too. It's been shown to help promote weight loss, slows cardiovascular disease progression, probably through that. We're finding some evidence that it just kind of improves overall gut health, can improve fertility, and slow tumor progression. It's a little more kind of sciencey stuff, but a lot of kind of resurgence of research around metformin these days. So metformin is really a mainstay in the treatment of diabetes, and it does not cause hypoglycemia.
Great. So metformin doesn't cause hypoglycemia. So then I don't really need to worry about this medication, right?
Not so quick. So it can cause lactic acidosis, right? And patients are at higher risk for this lactic acidosis if they have renal insufficiency too. The mechanisms are pretty complicated, but the takeaway is that if a patient is in lactic acidosis and it's deemed to be metformin associated, it does have somewhere from a 30 to 50% mortality rate. So it is something that's very serious that we do take seriously.
Wow. So can you talk to me about the classic patient that we see this happen in? Like, when should I think about it pre-hospitally, and what is such a patient going to?
What does a patient look like when they have lactic acidosis? They're sick. They've got a metabolic acidosis. They might be trying to compensate respiratory. They might sort of look like they have DKA, but they may or may not have hyperglycemia. But essentially, they look sick. This may be a patient with lots of comorbidities. They might have some renal insufficiency also. But the lactate that we get on these folks with a true metformin lactic acidosis isn't like a 3 or 4 level of lactate. This is like kind of what we call a type 2 lactic acidosis. And this is like a lactate of 10 to 20 that these patients have a severe lactic acidosis and they can be very sick.
And which type of patient gets this? Like what sets you up for it?
Yeah, it's patients that are taking a lot of metformin, maybe more than is what's prescribed, or patients with chronic kidney disease. There's a cutoff on where we try not to use metformin below a creatinine clearance of 30 to 45. So really someone with a pre-existing or maybe an acute kidney injury.
Okay. So just to summarize, make sure I understand that correctly, we should think about this in a patient who either has admitted to taking a large amount of metformin or for whatever reason, they've placed themselves at risk for an acute kidney injury or acute on chronic kidney injury. So somebody who maybe has some underlying renal disease and hasn't been eating, hasn't been drinking fluids, or for whatever reason may have developed a kidney injury. And then they're going to look almost like they have DKA because they have such a high lactic acidosis that they're trying to compensate with fast, deep respirations that you may even see those Kussmaul type respirations in them.
Yep, I think that's a great summary. Just a really profound metabolic acidosis.
So these are the classics. What about the newer agents? What are these and what do they do?
Yeah, so we're just really scraping the tip of the iceberg here with medications for diabetes. There's a whole bunch of newer ones that have come on the market in the last 10 years or so. There's some other subcutaneous injections that aren't insulin, but they're insulin-like, they're GLP-1 agonists or glucagon-like peptide 1. And essentially, these are sub-Q injections. The first one that was approved around 2010 was Victoza, so you might have heard of that. And that was a once-daily sub-Q injection. Trulicity is another one, and Ozempic is a newer one you may have seen commercials about, and I'm not here to endorse any of these, but they are new drugs, and the Trulicity and the Ozempic are once-weekly sub-Q injections, and so these are very appealing for folks. Sometimes they're prescribed for obesity also. They can suppress appetite and inhibit glucagon release and do sort of a variety of things. They can stimulate insulin from the pancreas also. But it's really important that it does this differently than those sulfonylureas we're talking about. Insulin's only released from the pancreas in the presence of glucose. So it's a glucose-dependent insulin release. So therefore, hypoglycemia is rare in these. And like I said, a lot of these medications are once weekly. They come as pens, like a subcutaneous pen where patients can dial in a specific dose. So you might see this and say, oh, that's an insulin pen. Well, not quite. But these are new drugs. They're pretty popular drugs used for, again, like I said, weight loss and also type 2 diabetes.
And you said they're not supposed to cause hypoglycemia because of the mechanisms that you just went through, but that they can occasionally. Is there anything that might tell us that this might have happened, or is it kind of just rare and you have to know about it?
Right. Great point. So, essentially if you see a patient and they're hypoglycemic and that's the only medication they take, or that's one of them, and you know that they don't take insulin, a lot of pharmacists feel that the hypoglycemia can happen with these, and it's probably underreported.
What are the other medications?
Then kind of we go down a list of a whole bunch of other medications. There's a lot of diabetic medications that we don't use as much anymore, but a few of them that you might see are DPP-4 inhibitors. These are linagliptin and sitagliptin are two. The brand names on those are Tradjenta or Januvia. I don't have a whole lot to say about these, except, they really don't cause a lot of hypoglycemia. They're more sort of diabetic, maintenance medications. But finally, I do want to talk for a minute about a class of medications called SGLT2 inhibitors. So this is a new class of medication, and they're gaining multiple indications. In other words, you can use them for things other than diabetes. They're gaining new indications for heart failure. And I'll tell you why in a minute. But so the mechanism of these SGLT2 inhibitors, I'll give you an example of some of the names, is canaglivlosin or empagliflozin. And
super easy to remember.
It's a tongue twister. But glivlosin is the suffix on these that it is consistent throughout this whole class. So the mechanism of these is interesting. So it's this like sodium glucose transport protein number 2, SGLT2. Well, this can also act as sort of an osmotic diuretic effect. Wherever large molecules go, water follows that. And so that's how it gained FDA approval for sort of heart failure. That's how I think that I tie the mechanism into how it can kind of maybe mildly reduce some fluid overload in heart failure and keep folks kind of euglycemic, because the whole heart failure, diabetes, metabolic syndrome all kind of go hand in hand. Now, there's an interesting side effect of these drugs that you'll read in the package insert. A lot of these kind of were evolved and were reported more post-approval and post-marketing, but it's euglycemic ketoacidosis. So these can result in a sort of DKA. This happens most when patients are uncontrolled, right? This uncontrolled diabetic, but they're on this SGLT2 inhibitor. And so they have high levels of glucose in the body, but it's all being excreted out pretty quickly. So a patient ends up being euglycemic, but there's still a suppression of insulin happening and increased lipolysis and increased sort of intracellular breakdown of fatty acids, just like a DKA pathophysiology and ketone production. And what's tricky about this is patients can show up in a euglycemic state. They don't have that high reading on the glucometer. They might have a blood sugar of 150 or 180, but they're also in DKA.
Yeah, that's scary and seems unfair. Because historically we've defined DKA, as one of the criteria, blood sugar being above 200. And so these patients will show up still with elevated blood sugars, but often less than 200, but still have large amounts of ketone bodies in their bloodstream when we test them, and they'll look like they're in DKA, and they are in DKA, even though their sugar's only 150 or 180 because of this weird mechanism that you talked about. And so seems unfair, something you need to look out for.
Yeah, it's super unfair. The patient may look like they're DKA. They might have those Kussmaul respirations. They might be blowing off CO2. And what tricks you until you take their beta hydroxybutyrate, their ketones, and take their pH and kind of get a whole panel back, which is tough to do pre-hospital. You won't know this. So sort of be wary if you see this class of medication and patient looks like they're in DKA and they're euglycemic. They still could be in a ketoacidotic state.
All right, so that concludes all the classes of new medications now for these diabetic patients. How do we keep all of these medications safe? You threw out, we just talked about the classes, but within each of these classes, there's maybe 3-4 medications that all have different names. And so how do we keep all of these straight when we're in a stressful situation with a sick patient?
Yeah, it's really tough, Ross, and I'm glad you mentioned that. Sometimes you just have to look these up, but thankfully we have devices around us. We can look these up. I would maybe put these in a gradient from insulin, sulfonylurea, down to the GLP-1 agonist as being able to cause some hypoglycemia. And then finally with that last class, the empagliflozin and canagliflozin, the SGLT2 inhibitors that, maybe they don't cause a lot of hypoglycemia, but you might want to be worried about a euglycemic DKA.
Yeah, I'm with you. That's totally what I do in the emergency department. I don't have any of these medications memorized, but I know that when a patient's coming in hypoglycemic, I need to worry about insulin, sulfonylureas, and maybe GLP-1s. And then I know that I need to worry about euglycemic DKA with SGLT2 inhibitors. And then I know I need to worry about lactic acidosis in those rare patients and metformin. And then I kind of care less about the DPP-4s.
Yeah, there's DPP-4s. There's a bunch of other diabetic medications that we don't use a whole lot anymore. And I care about all meds and I treat them all fairly, but I'm less concerned. We don't see them as much, and they certainly don't cause a large degree of hypoglycemia.